due to our lifestyles, due to our diets, lack of exercise. We all like watching our sports and watching this and watching that, but very few of us play those sports.
Right, that's true.
A little bit worrying.
Yeah, and something we always talk about are heart attacks and high cholesterol and things like that. Something we talk very little about is cardiac arrhythmias. How significant or how much of an impact does it have on one's life, and what is it?
So let's take a few steps back from all of this for those listeners, just to sort of explain what the heart is all about.
Okay.
The heart's an organ that pumps blood around the body. It has a large amount of muscle around its chambers that does the pumping. It also has valves within it that control the flow of blood in particular directions. On the surface of the heart, there are a number of arteries that run around supplying these muscles with blood to allow the heart to function properly. The heart attack you mentioned earlier is all about blocking of these arteries, narrowing these arteries, and having not enough blood flow to that muscle, leading to death of that muscle.
Right.
To make this entire system work, we have a very fancy electrical system in the heart. It starts in one of the chambers called the right atrium and then passes down through very specialized fibers to the ventricles, where it helps the ventricles to contract and work. To make it even simpler, it's probably like the electrical system in a car, where the main part of the engine would be the muscle, they've got the valves, and the spark plug and electrical system will be what actually gets the engine to work. Without it, the engine will not work.
Okay.
So the electrical system plays a very important role in the function of the heart. It helps the two chambers contract properly and in coordination. So the top chambers help fill the main ones, and then the main ones contract to get the blood out of the heart. So it's a very integral part of cardiac function.
Okay.
Arrhythmias just means funny heartbeat. Okay. And it could cover a whole broad sort of field. It could be all the way from damage to the electrical system of the heart, leading to slow heartbeats, leading to heartbeats that are dropped, leading to abnormal heartbeats coming off from all parts of the heart, and leading to very fast heartbeats due to various electrical conditions within the heart. So it's actually a very large field.
Right. Okay. So what's the most common? I know people usually talk about ectopic beats, and I admit ectopic beats and arrhythmias all part and parcel of the same thing.
All part and parcel of the same thing. So ectopic beats is literally an extra heartbeat that happens.
Okay.
The ones they feel are often the ones that come from the ventricle, the ventricular ectopic beats. There's often some sort of scar tissue or fibrotic area within the ventricle, and a beat just sets off by itself. It normally occurs shortly after a normal beat, and then there's a little bit of a pause that people feel afterwards. And then what happens, because there's a pause, the heart actually fills better.
Okay.
And the beat after that's the beat they feel. So they don't actually feel the ectopic. They often feel the beat afterwards, because it's a much bigger, when the heart contracts, it's a much bigger volume in the heart, so you actually feel that much more afterwards.
Right.
So that's what they pick up as an extra beat.
Okay.
It's normal in a lot of people, often brought on and made worse with excitement, anxiety, stress, but also things like coffee or caffeine and smoking, nicotine, etc. can actually exacerbate all of these.
Okay.
So I don't think there's anything to worry about. What we do need to worry about is if you're having lots of them and they're occurring in sort of triplets, and 3 and 4 and 5 of them occurring rapidly with each other, then we need to start worrying. You can feel it in your pulse. You could actually just feel it in your chest as well. And then what I'd suggest, again, with all these electrical problems, you need an ECG. And ideally you need an ECG when these things happen. An ECG in between may be absolutely normal. It's useful, but may be absolutely normal. However, when these funny heartbeats happen, an ECG will then be able to tell us what's going on in the heart.
Okay. A reminder to our listeners that you can call us with any questions, doubts on our WhatsApp line on 060-904-1056. You can send us a message, and I'm sure Dr. Hansa will be able to answer it for you. Doc, what are the common causes of these irregular heartbeats?
So we discussed ectopics already, and they could be coming out of the blue. They happen in lots of people, nothing to worry about. Oh, let's just take a few steps back, sorry.
Okay.
Everyone talks about ECGs. The ECG is actually the electrical system in the heart. It's the electrical current running through the heart, and how it runs through the heart, either normally or abnormally due to various issues and damage within the heart or something like that. So that's what ECG is all about. So an ECG actually looks at the electrical system of the heart. It doesn't look at the arteries. It doesn't look at the muscles. It looks at the electrical system of the heart. From that, we can infer that maybe the muscle's too thick, or something else is happening, or there may have been a previous heart attack or whatever, but it's the electrical system of the heart we're looking at. The common sort of arrhythmias we pick up, the ones we always talk about, we see quite often, something like atrial fibrillation. So that's commonly what happens. It happens more in elderly patients. It happens in people who had large hearts, damaged heart muscle. And that is basically a fast, irregular heartbeat. People feel palpitations, their heart's racing. In the older patients, often those who have heart failure, cardiomyopathies, etc. Often it's the atria that start firing irregularly and funnily. And when these atria start firing, the signal goes through to the ventricle very, very quickly, and some of those signals are then transmitted through, and the ventricle then contracts irregularly. So it's an irregular heartbeat. The reason why we need to understand this and why we need to seek help for this is that with a very fast heartbeat, your heart's under strain, especially if it's going to 170, 180, 200. It can damage your ventricle if it's there for too long. It can lead to all kinds of other issues. And then, of course, the other big problem with atrial fibrillation is because the atria are not pumping and they're just vibrating, fibrillating, as we say, they can develop little clots in them. And if those clots come loose, you could have a stroke. So we need to slow the heart down, and we need to give you something sort of blood thinners to actually thin it. And this doesn't we're not talking about aspirin, which is antiplatelet, which is to do with coronary artery disease. We're talking about stuff like warfarin or one of the newer agents like Xarelto or one of the other ones. So one of the newer agents to help thin the blood to stop you having a stroke. So very, very useful. We do try and get the heart rate back to normal. We either electrically cardiovert the heart back to normal, and then we do. I'm just a normal cardiologist. I'm a plumber. We do electrical work as well, but we do have specialized cardiologists. There are only a few in the country that do electrical work within the heart, and they're very good at that. And they can actually find the source of these funny heartbeats, often in the pulmonary veins, and ablate them. It's called having an ablation, and stop it. So,
for the benefit of our listeners, you mentioned palpitations. What are palpitations?
So again, palpitations is just a feeling. It's a feeling that you notice your heart beating. So you notice your heart beating fast or slow. Often it's either not slow, but it's actually a felt heartbeat. You actually notice your heartbeat, which people call palpitations. Oh, it's a fast heartbeat you feel. That people describe as palpitations. And this could be various things. We discussed atrial fibrillation, so that's the one thing. The one other possibility people have, especially young people, young females, is they could have what we call a short circuit in the heart. It's not very common. A lot of people actually have them. But there's a whole set of circumstances you need where you have an extra heartbeat very close to where that short circuit is to set the whole thing in motion. And once it starts off, your heart can beat very fast, regularly. And again, rates can go up to very, very fast. 160, 170, 180, 200. It's very distressing for the person. They feel anxious. They get short of breath. They have tight chests. And so, again, they need an ECG, and there are various techniques we can use to actually slow it down or even convert them back to the normal rhythm.
So you mentioned that, it's a normal part of life to have these arrhythmias, excitement, anger, caffeine, things like that. What are some of the pathological causes of these arrhythmias?
So, again, we have covered part of it where each one has sort of different kind of pathology. So we were talking about the short circuit in the heart. There's actually a short circuit pathway either very next to the AV node or a bit further away that causes what we call a re-entry tachycardia. That causes this loop inside the heart where the heart's beating faster and faster and faster and keeps at this fast rate. There are abnormalities in the atria where the atria are dilated and stretched and damaged, and that can cause atrial fibrillation. There are scar and fibrous tissue inside the ventricles, either from previous heart attack, myocarditis, some inflammation causing extra heartbeats from within the heart. And then, of course, there could be abnormal conduction system abnormalities as well, which gets a bit more complicated, but these can also lead to then abnormal rhythms, funny heartbeats, and even sudden cardiac death. But listeners must understand, these are not very common. And we see a lot of people refer to us with palpitations, a hell of a lot referred with palpitations, and we then do what we call a Holter, 24-hour ECG on them, hoping to, we need to get an ECG during the palpitations. If someone has a 24-hour Holter or 24-hour ECG done, and they don't have any funny rhythms or funny palpitations during that time, not very helpful. There are very fancy devices we can now implant into people's chests, called loop recorders. They then continuously monitor the heart for a couple of years.
Okay.
And they if somebody has a funny event, they can come to us. We talk to these devices wirelessly. These are planted not into the chest, but into the surface, just on the surface, under the skin.
Okay.
So not like into the chest, but onto the chest. And we can talk to them, then assess what sort of rhythm they're having. Interestingly, a lot of people have palpitations, and often we find normal ECG is this slightly accelerated heart rate. They may be having issues with anxiety, maybe stress related, and the heartbeat at this time is actually absolutely normal.
Okay.
So again, not all palpitations are pathological. A lot of them are actually just stress, anxiety, or someone just a bit more aware of their heartbeat.
So what are some of the symptoms a person can look for, to say that they need
It's hard to
see a
tell
doctor?
because what they generally have is they feel their heart beating first.
Right.
If it goes on and it's very fast, one of the best things to do is actually take a pulse. Just feel next to your thumb on the thumb side of your arm, just where your arm meets your wrist meets your hand. You feel your pulse there. You can feel it in the neck. You'll feel your pulse racing, and you can tell whether it's fast and regular, irregular, or whatever. Or is it really fast? Sometimes people feel their heart beating, but when you take their pulse, it's 70 to 80 beats a minute. Not very fast at all. So that's what they have. They have fluttering in the chest. They may get sweaty and clammy from it. They may feel unwell. And in the more extreme forms, you can get dizzy and you can pass out. These are more complex arrhythmias, more worrying ones, probably ventricular in origin, that actually affect cardiac output, and then that could be quite dangerous. So again, it's just an awareness of a very fast heartbeat, either regular or irregular, and that's what they have. That's what they feel.
Okay, so they should see a cardiologist. They should have it
I think
diagnosed
GPs do a
properly.
very good job as well, though.
Right.
So if you're having an arrhythmia, you need to get an ECG pretty quickly. A lot of GPs now have ECG machines or emergency units as well, and you need to go in and have an ECG done first and foremost.
Okay.
It's very difficult to walk into my office and just have an ECG done. Not that easy. So I think just go to your closest medical facility and get an ECG first. If these are occurring regularly, speak to your GP, and they can always be referred on then to one of us to have a look at.
Okay, so you spoke about a person having a 24-hour ECG monitor, etc. Quite a few of our listeners, and I'm quite sure more than 50% of our listeners actually don't have that advantage of being on medical aid and things like that. So, as a government patient who is experiencing these kind of things, what can they expect? What do they do?
It's a very complicated question. It's and my heart does go out to people without medical aid and funding. I mean, we do have technologists available that can do halters in private. I'm currently unsure of their charges, but there are independent technologists that will do it for us and see.
Okay.
But again, I advise a bit against it unless you need to be properly assessed beforehand with a very competent GP or somebody that understands what's happening. Because if these events are not occurring frequently, if they're occurring once a month, once every 3 months, once every 6 months, the use of having a halter is very little, because it's highly likely you spend a lot of money, and things are tight these days, and we understand people don't have ready finance, and you'll pick up nothing. If you tell me you're having palpitations every day, every second day, then it's more useful to do a halter, because then your pickup rate will be much higher. It's highly likely you will have the palpitations when that 24-hour ECG is on. It's basically literally an ECG. It's got 7 electrodes that we stick to the chest. They're attached to a little box that you carry around with you with a battery in it, and it will record for 24, even 48 hours. So it is useful, but you have to be having these events frequently. And it's got to be attached to you when you're having these events.
Okay, so are these events more common in the elderly who've already had cardiac events and things like that? Or is it common now amongst our youngsters because of drug use?
Everywhere. There's different kinds of arrhythmias that have different population groups and ages that they occur in. So basically with the sort of re-entry tachycardias, it's more the young people, more the female patients, as opposed to atrial fibrillation, which again happens more in the elderly patients. There are other things as well we see in our not so much in our community, but things like alcohol, binge drinking, etc., which can precipitate some of these arrhythmias and funny heartbeats. Drugs, again, especially the stimulants, can sort of push your heart rate up. can give you arrhythmias if you're predisposed to having them, and can even give you a heart attack.
Okay.
Cocaine, typically, can cause severe spasm of your arteries, leading to heart attacks, which we actually have seen in practice, not infrequently. So, yeah, drugs are just as bad. Other stimulants that people take as well, high-dose caffeine. People who gym a lot and train a lot take high-dose caffeine supplements, and that can lead to arrhythmias.
Diet pills as well. And
diet pills can take it. Sometimes some of these diet pills, unfortunately, do have high amounts of thyroid hormone and all kinds of other things in it as well. We've had people on people with palpitations on these. I'm not sure where they pick up these diet pills on the street. These are not official pills that are sanctioned. And coming in, we do routine tests on them. We found thyroid hormones through the roof. So obviously they had altroxin. Someone's been crushing up thyroid hormones, sticking into so-called diet pills and making people toxic, which is very bad. So yeah, it depends what people take out there. But any of these things can exacerbate these funny heartbeats.
Okay, you mentioned the thyroid there. I know that thyroid is also one of the common causes of
it can cause what we often see, atrial fibrillation. That's the common one. One of the things we do have is when someone does have any arrhythmia, to be honest, but especially atrial fibrillation, thyroid function is definitely checked in these patients. The other thing thyroid hormone can do is because thyroid hormones switch on the body. So if your thyroid hormone's very high, your body's switched on. That's why they're skinnier, they have palpitations, they lose weight, you're hungry a lot, you're very agitated, restless. It's like just you're very, very switched on. And in that sort of state, you can actually push the heart harder and accelerate any sort of abnormal rhythms that are there.
Okay. Reminder to our listeners that you can send us a message on WhatsApp on 060-904-1056. We have one question here that's not related to our topic, but I'm sure you can answer this as a cardiologist. Does fatigued legs and feet have anything to do with the heart? A very generalized question.
There are many causes of fatigue, firstly. There are a lot of causes of fatigue out there. Thyroid hormone, for example, if you're hypothyroid, which is nothing to do with the heart, you could have swollen legs, fatigue, tiredness and stuff as well. From a cardiac point of view, the things to worry about are cardiac failure. If your heart pump muscle is not working very well, and that can lead to fatigue and tiredness. If you've got extreme coronary artery disease, again, that won't give you quite leg tiredness, that'll give you tiredness and fatigue of the body as well. More with leg tiredness, I'd worry more about firstly obesity, diet, diabetes and peripheral neuropathy, other endocrine disorders. If that's all it's affecting and there's no cardiac symptoms, then there's lots of other issues to look for first.
Okay. And also, Doc, we're talking about people who've had a heart attack already, and they put on a tablet called captopril and also Cardicor. Are these can these drugs be used for people who have anxiety and things like that also?
The managed anxiety is a bit complicated, and I wouldn't just so people who have palpitations have either a rapid heartbeat or their awareness of the heartbeat. Captopril, no, that's an ACE inhibitor, and I wouldn't use that. That's a heart failure therapy, pressure, etc. But beta blockers have been used in patients that are anxious. They're used to slow down the heartbeat a little bit, so people can actually feel a bit more rested. They don't have the sort of adrenergic response. It's a beta blocker. It blocks your receptors, so it does cause a bit of more calmness and relaxation. I've actually had patients who were on beta blockers, and I stopped them, and they got very irritated because it really made them feel better and helped them cope with things. More importantly, I think anxiety needs to be addressed. You need to see a psychotherapist. You need to talk about it. You need to have it sorted out. Putting them on beta blockers purely relieves some of the symptoms, but doesn't actually get to the cause of the anxiety, which is more important, I think, to address.
We're talking today to Dr. Cassim Hansa, and our topic is cardiac arrhythmias. Doc, let's talk about some of the treatments that are available for this kind of condition.
So, it all depends on the type of arrhythmia. Let's deal with the first one. We did atrial fibrillation. We, depending on the age and the person, we like to get the person back to a normal rhythm. We can use drugs, or sometimes we put them to sleep and shock them to get the heart back to normal. We try and control if we can't do that and that fails, and we control the rate with drugs, and we put them on blood thinners. If it's a short circuit inside the heart, we can try medication first, things like beta blockers. However, if this thing continues, then a very good thing is we spoke about the cardiac electricians, and they can burn inside the heart to it's called an ablation, and ablate this sort of funny rhythm.
Right.
The one thing we haven't mentioned or gone into detail about is the slow heartbeats. You can have what we call bradycardia, is where your heart goes slow, often because of failure of the conduction system or a block between the top and the bottom chamber. So the signal from the top chamber doesn't go to the bottom chamber. And these heart rates can go very, very slow, and sometimes so slow that you either pass out, fall down, and eventually the heart will stop. To manage these is different. With failure of the electrical conduction system, you need something to take on the job of the electrical system. And the ideal system we have there is something called a pacemaker. So that's a box we implant into the anterior chest wall, often just on the left side, just below the clavicle. We make a small cut down. We then put leads into the heart, commonly 2 leads, one into the atria, which is the top chamber of the heart on the right side, and the other lead goes to the ventricle, which is the lower chamber. This then allows us to pace the heart. We can send a signal to the top chamber and then a signal to the bottom chamber sequentially, so the heart beats in a normal sort of fashion. And these things last 10, 12, 15 years sometimes, depending on how often you use it. So they last very well. They're fairly robust. They're extremely safe. And the other important thing is, when regular checkups are important, and we do talk to these devices wirelessly, and we can see that the battery now is slowly wearing out, and then we literally, before the battery runs out, we replace just the device. We don't replace the wires, and they work phenomenally well. Associated with this, or another sort of thing we have, is extremely fancy pacemakers. There are certain pacemakers we use for heart failure, but there is a particular pacemaker called an implantable cardiac defibrillator. So defibrillation is the shocking of the heart, where those machines you see on TV and stuff, when someone collapses and everyone shouts clear and they stick the paddles on the chest and they push the buttons. That's a defibrillator. There are certain arrhythmias which are noxious. These are arrhythmias that often are ventricular in origin. The heart beats either very, very fast or just fibrillates, like the atria fibrillates, so the ventricle can also fibrillate and beat erratically, very, very fast and ineffectually with no heart output. These things will lead to death. So there is a very, very fancy pacemaker, inverted commas, we implant a much larger box, which can then send an electric current through the heart if necessary, to revert you back to a normal rhythm, or try and pace you out of that. They're very clever and phenomenal devices, however extremely complicated. So again, this is very advanced sort of management of these sort of palpitations. They're not the normal palpitations you have.
Okay, and I believe some of your colleagues were one of the first people to implant one of the smallest pacemakers a couple of months ago.
Yes, there's Dr. Brian Vezi, who works with us. He's an electrophysiologist, the cardiac electrician, good man, and he, in conjunction with Dr. Ashley Chin from Cape Town, implanted a device recently. These are, again, very new devices, not commonly used, single chamber pacemaker that was implanted into the heart. Very nice device. Why are we talking about these sort of devices? If you're having palpitations and passing out, it's very serious. We need to see you. You need to get referred into cardiology to assessment, because these very fast palpitations leading to you passing out, or even if you had a palpitation, passed out and had to be shocked out of it, these are very serious arrhythmias we're talking about, that so then do require treatment at a much higher level.
Okay, so it causes like an uncoordinated kind of pump, which then doesn't allow your body to get the
so it runs off things like ventricular tachycardia and stuff. So your heart doesn't beat effectively and efficiently, and your cardiac output drops, leading to you passing out.
We have another question here, Doc. Salams, good evening to the doctor. My cholesterol is 5.9, male 48 with family history. What do you recommend? Does omega-3, K2, etc. help? Also been monitoring my pulse rate. Certain times it is 55. Is this a concern? Calcium levels just above normal.
Calcium levels. Assalamu alaikum wa rahmatullahi wa barakatuh. Cholesterol in isolation is not the end of the world. And 5.9 is elevated. We don't know what the breakdown of that is, however, which would be useful. But what we do need to remember is that the management of cholesterol is not statins. The management of cholesterol is to do with exercise, diet, eating correctly, especially if it's an isolated problem, prior to thinking of dumping people on statins and all that stuff. So statins have a bad rep, unfortunately, and they are useful. There are times we like to use them. But as a first line, if all you have is an elevated cholesterol and you're relatively young, diet, exercise are very useful. Then there are alternate agents one can try. Omegas, not so much, but there are other agents that have things like polycosanol in them and stuff that we can try to reduce the cholesterol. It's always worth a try. If it doesn't work in the end, we can always do something else. A family history is of concern of heart disease. They probably also got a family history of hypercholesteremia, but other things we worry about. So yes, cholesterol is elevated. What else are you doing in your life? Because the smoking is a big issue. People with elevated cholesterol is one hit already. Smoking is another big risk factor for coronary disease. So again, multiple risk factors are a problem. The fact that his pulse rate is slow, I'm not sure how he measures the pulse rate.
It's quite low, huh? It's quite low, 55.
It's low, but we're not sure if he's on any medication. Firstly, that's dropping it low. Secondly, we're not sure how it's been measured. Has it been measured properly at the pulse and stuff? Is he very fit and well trained? We don't know. Or is it measured by his watch? Now, these watches that people wear are great to sort of give you an idea of what the pulse is doing, but they are innately inaccurate. An ECG does it better, or a chest strap can pick up the heart rate much better. So I strongly advise my patients as well as when they train and stuff to monitor heart rate, get a chest strap. That will then link to their watch or link to their phone or whatever, link to the smart device, and then that can tell them their heart rate much, much better. Heart rates from wristwatches alone, I have also got a very fancy smartwatch, and they very often misread. So again, I suspect he may have a watch that shows him his heart rate to be low. I think it needs to be taken correctly and checked up.
Okay, I hope that answers the question for you. Doc, you mentioned about statins not being the first-line treatment. I share that opinion with you. I'm glad that some cardiologists also share that. I know a lot of people who are taking statins complaining of pains in the joints and problems with their libido and all these things.
Absolutely, and unfortunately, the excess use of statins, I think, is a problem. If someone has had an event, a coronary event, etc., they should be on a statin.
Right.
Okay, there's no argument with that. The problem is that every time people see a slightly elevated cholesterol, they bang people, and a lot of our colleagues just put people on statins. Okay. And that overuse of statins is what's led to the side effects in these people who are otherwise healthy and well, and sometimes disabling. We've had patients, myself, I put them on statins, with pre-existing disease that required statins, and still, they literally tell you they can't get out of bed the next day.
Yeah.
So, there are a couple of things we can do. One, we can change the statin to a lower dose and to an alternate. There are several different statins available. We can try a different statin. That helps. We certainly find that definitely helps. Coenzyme Q10 has been told that it helps, and some people do have benefit from it as well. Okay. So if you have to be on a statin, coenzyme Q10 helps as well. So you can go on to that. There are other alternatives as well, though. There are other agents we can use besides statins to help reduce cholesterol as well. Commonly used, we use fibrates, and the other one is ezetimibe. These do help reduce cholesterol without the entire effect of the statins. There are things like niacin and stuff we use as well, but they're not as readily available, and of course they have side effects, commonly like as flushing and that sort of stuff. So people, and the doses they required, they will cause flushing. So unfortunately, and we don't have sustained release niacin in this country.
Doc, is there anything else you'd like to say about the treatments, or should we move on to the topic of...
We've got lots of we can talk lots of general stuff. I mean, the bottom line is that if you're having palpitations and funny heartbeats, you need to have an ECG and stuff done at that stage. You can go to your GP, because I think that's a very good first line. Speak to them, get an ECG, and get referred on to us. There are different arrhythmias that happen in the different age groups. The things to worry about are if you're having palpitations with dizziness or syncope, passing out with these things, that's a worry. That needs help. In the elderly patients, the irregular heartbeats are the one we worry about, and often again these are atrial fibrillation that needs to be identified, because they have other consequences if we don't treat them. So not all palpitations are bad. You need to have them assessed first, and then we can take it further.
Okay, so like I mentioned earlier, there's a lot of queries from patients, especially cardiac patients, who want to know about drugs that are used to treat
ED
or erectile dysfunction. a lot of them are scared to take it. A lot of them have tried it once or twice, and I don't know whether it's psychological or not, but they tend to have irregular heartbeats. I don't know whether they imagine it or what, but they're really scared. What's your take on this?
So, firstly, cardiac patients themselves have a predisposition to impotence. Actually, a lot of patients with impotence, there was a study done a while ago, showed that they will eventually have a cardiac or an intracranial event. So it's very much linked. So if someone presents with impotence, you have to worry about the pre-existence of cardiac disease.
Right.
It's the drugs we use, especially beta blockers and statins are a known cause for this, and it is a problem. Again, it's very difficult to advise people what to do on air without knowing their proper histories and stuff. And I'm just worried that people will do the wrong thing, taking sort of phosphodiesterase inhibitors. So there are drugs you can use. And of course, the phosphodiesterase inhibitors, the common one we talk about is Viagra. But there are some very, very strong issues with heart patients taking it. So there's nothing wrong with them taking it. The first one is, are they on nitrates? A lot of heart patients are on things like Elantin's no longer available, but Ismo or Monicor or all the tablets they put on their tongue regularly. Right. These things cannot be mixed with these phosphodiesterase inhibitors because that cause profound changes in blood pressure and lead to collapse, heart attacks, death even. So if someone is on a nitrate, these are no-no. Okay, so it's very, very important. And I think you need to check with your doctor. If you're a cardiac patient and you wish to take these drugs, you need to check with your doctor because you may not know you're on one of these things.
Yeah, that's true.
And you may just take it and you may just think, well, I mean, to be honest, if I ask a lot of my patients if they're on nitrate, they have no clue.
Yeah.
You know, so, and yet they're on Ismo. So what I'm saying is they may not understand. So it's very important to have it checked up. That said, even after a heart attack, if you're well, if you've recovered, if you're not on a nitrate, then yes, there is medication you can use, and phosphodiesterase inhibitors is what we do use in these patients. And the common ones are Viagra, Levitra, and Cialis. They work well, they're effective, and they do give you something back in your life that you may be missing quite seriously, and that's important in life, and it's important in married life as well. You have to fulfill your spouse's duties and stuff as well, and this is one of them, and if you can't, it leads to all kinds of psychological issues and stuff. So I think it's very important, but again, very, very strongly, you have to have this checked up with your doctor. Do not go there. Secondly, and a big problem I found is don't buy stuff on the street. There is a ton of stuff available out there. You drive down Sparks Road and someone will come up to your door window and sell you stuff. It happened to me. And he came with his little diamond-shaped blue pills and wanted me if I would buy some. And I asked him what it is. He says, no, it's very, very good for you. Doesn't know who I am, of course. So I had to go look at them, and it was called Niagara.
Yeah, no, all the eyeglasses.
I was like, what?
All the generics,
like, so we don't know what's contained in these agents. We don't know the purity. We don't know the concentrations and stuff like that. So as a cardiac patient, you shouldn't be taking a risk taking anything off the street or taking any of these things. You need to go to the pharmacy, get the official stuff, get the right stuff, and get the original stuff, basically, because we got more faith in that. But again, check it out first with your doctor. Now, it doesn't have to be a cardiologist, but with a good GP, you can check it up, chat to him about it first before taking it. Is there something else you can do if you can't take these agents?
Is there anything?
It's a family station, this.
Okay.
There are certain devices and stuff you can use that are useful and very helpful, but it'll be a bit difficult for me to discuss it on air. I think in this sort of channel and stuff, it's going to be complicated.
At that for now.
Yeah.
Okay, we have one of our listeners here saying, Salams, Dr. Hansa. I'm female, 74 years old. I went into heart failure 3 years ago. Palpitations, arrhythmias, etc. Admitted for 13 days at Mount Edgecombe and Intubani for 13 days. I'm a doc. My doc referred me to see Dr. Bezi in a week. I was reluctant because wasn't sure if it is the right doctor, but listening to you, I think it's the way to go. I think it's just a comment. There's no question there as well. Another question we have is, Doc, Assalamu alaikum, love the program. I have cholesterol problem. It was second, had to go on it was high, and it was uncontrolled, had to go on a statin called Ellipto, 10 milligrams. It brought it down, and it's now 3.2, but muscle pains are bad. And please advise Mrs. Adam, PMB. So you did mention that unless a person has had some sort of cardiac event, then it's a must that they must go on to statins.
So statins, again, we don't know his full history. We don't know if he's had an event before. We're not sure if there are other risk factors involved, like smoking, family history, diabetes, hypertension. So it's hard to answer that just outright. However, if you're having severe pain on 10 milligrams of atorvastatin, that's a very low dose. You can try rosuvastatin 5 milligrams. It may be useful, even simvastatin 10 milligrams, and see if that makes any difference. If it's isolated hypercholesteremia with nothing else, no other risk factors, we can then go on to something like one of the other agents, a fibrate or ezetimibe. But check with somebody, because you shouldn't be suffering. The whole idea of statins is to bring down your cholesterol, but not make your life miserable. Otherwise there's no point. As far as the other lady goes with arrhythmias, yes, Dr. Brian Vezi is a very good electrophysiologist here in Durban, and currently working at our hospital. But he is the heart electrician. So if there is an electrical problem you're having,
he can solve it.
And more often than not, if she's got severe heart failure, I suspect she's going to be referred on for implantation of probably one of these fancy pacemakers to help her heart beat better.
Okay, I hope that answers that for you, Mrs. Adam. Doc, we've come to the end of the show now. Any last parting shots you'd like to give?
Don't take your heart for granted. You've only got one. We have a transplant program which is the list is excessively wrong, and most people never get another heart. So if you don't take care of it when you're young, if you don't eat healthy, live healthy, don't abuse yourself, stop smoking. If you carry on smoking this, or don't stop smoking and carry on abusing yourself, you're going to have problems later on, and then you'll end up on our table.
Okay. I would like to thank you, Dr. Cassim Hansa, the cardiologist, our guest today. I'd like to thank my technician as well today, Zakaria, for a good job. And inshallah, we hope to have you with us on the airwaves next week at the same time. Assalamu alaikum wa rahmatullahi wa barakatuh.